Hello everyone, welcome back to my YouTube channel Speedy Dentistry. Today we'll be learning about cleft lip and palate. So basically it is the most common craniofacial deformity, while it is second most common congenital anomaly because the first one is clubfoot and second is cleft lip. So it is most common orofacial cleft. It requires a multidisciplinary approach. Incidence is 1 in 800 patients. Male children are more affected, while the isolated cleft palate is more in female patients. Unilaterally, it is 9 times more than the bilateral, and left side is affected twice than the right. For the historical perspective, it has been considered that a evil spirit has affected the child. Next, Buchai was the one who did first time closure of cleft lip in China. Secondly, the periods of Z-plasties. So, year 1952 and 1958 marked. Low triangular flap by Tennyson was given in year 1952, while in 1958, high Z-plasty by Millards was given. Third one is Diefenbach. Diefenbach said that one should separate the mucosa for proper closure. And fourth one is von Langenbach, who was the one who combined all the principles and said subperiosteal undermining should be done and mucoperiosteal flaps should be used for better healing. Now coming to the embryology. So face basically develops from frontonasal process and tissues of first pharyngeal arch. For the frontonasal process, it's given 2 median nasal process and 2 lateral nasal process, while the first pharyngeal arch provides pair of mandibular and pair of maxillary process. The maxillary process will further form the palatine process. These diagram shows the embryonic development. So this one is the frontonasal process. These are the nasal pits. These are the nasal pits. This marks the eye. And from first and second pharyngeal arches, there develops maxillary and mandibular process, and stomodium, which forms the future oral cavity. Now this is the lateral nasal process. Central part forms the medial nasal process. Both develops from frontonasal process. Third shows the eye coming laterally and nasolacrimal groove, development of nasolacrimal groove and philtrum. For the cleft lip patients, it can be unilateral, bilateral, and median cleft lip. For unilateral, it is maxillary prominence which fails to fuse with merged median nasal process. When bilaterally, it will be bilateral. And in bilateral cleft cases, Simonard's band will be present, which joins the lip on both sides of cleft lip. Third one is median cleft lip. This cleft lip is seen in Mohr's syndrome and it is a very rare condition. In this, 2 medial nasal processes fail to fuse with intermaxillary segments. Now coming to development of palate. So palate basically developed from frontonasal process forming primary palate and from the lateral palatine process forming secondary palate. Palatine process we have seen which develops from maxillary process, which is basically for first pharyngeal arch. So we have seen first pharyngeal arch and frontonasal process previously also. For the ossification, if ossification has not occurred, it leads to the formation of soft palate, while in presence of ossification, primary, anterior and secondary palate formation occurs, which will form the hard palate. At approximately 8th week of gestation, the lateral palatine process turns from vertical to horizontal and initiate fusion. This happens because mandible becomes prognathic. The mandible becomes prognathic and initiate fusion. And due to prognathism of mandible, tongue moves downward and gives space for the vertical to horizontal transfer of hard palate. This diagram shows these are the secondary palate, this is the primary palate, and this shows the incisive foramen. Now coming to the problems faced by the patients affected with cleft lip and cleft palate. So major problem is feeding since there is no negative pressure inside the mouth. Second one is the otitis media. This occurs because of abnormal muscle attachment and thus ear ventilation will be affected, leading to blockage of endotracheal tube and due to blockage. If this is a sewage pipe and there is some blockage, so what would be there? The fluid pressure inside will increase and inflammation will be there. Same occurs here also. For the third problem, there will be speech problems since there is no closure of nasopharynx and vulvopharyngeal incompetence, that VPI will be present. Now, how exactly the cleft lip and palate occurs? So the etiology part has genetic component. Here comes the etiology part. It is having genetic component, environmental factor, and third is syndromic. First one is when one child is affected, there are 2% chances. When one parent is affected, there are 6% chances. And when one child and one parent is affected, 15% chances are there. For the environmental causes, smoking, maternal smoking, and also maternal smoking, alcohol consumption. For smoking, it increases the chances of cleft lip and palate by 1:29 and 1:32 for cleft palate patients. Also, medicational usage like steroids, example prednisolone. The pregnant female is taking prednisolone. Even at the therapeutic dosage, it increases the chances of development of cleft by 3 to 4 times. Anticonvulsants like phenytoin, valproate, that increases the chances by 10 times, and chemotherapeutic agents like methotrexate. Next, folic acid deficiency is a star mark factor because this deficiency leads to cleft cases more commonly. Next this signifies the radiation. This one is for any kind of viral infection. So you can see in this diagram, this one basically stands for radiation and this one stands for viral infections. This tire should remind you of mechanical factors, like mechanical factors used for abortion, like uterine manipulation or hormonal therapy. Third one comes the syndromic. For syndromic, there could be a trisomy of chromosome 13 and 18. This leads to cleft. Second is non-Mendelian, that is Pyre-Robbins and Goldenhar syndrome. When for the Mendelian, it is VGT, that is van der Waals, Gordlin and Treacher-Collins syndrome. Unknown causes can be Kabuki syndrome and De Lange syndrome. Coming to the classification, the basic classification states that the cleft can be unilateral or bilateral. Unilateral can be complete or incomplete. Bilateral can also be complete and incomplete. Second is the Kanhan stripped Y classification. So this is the second. So what he stated that mark this as right and this one is left. So 1 is for lip, 2 is for alveolus, and this is hard palate anterior to incisive foramen. This is incisive foramen. So this will be hard palate anterior to incisive foramen. 1, 2, 3, then move from 4, 5, 6, that is the left side, and then moves downward 7, 8, 9. So he classified it as Y shape. That's why it is Y stripped Y classification. 7 stands for his hard palate posterior to incisive foramen, and 8 and 9 are soft palate. Later, it was modified and known as modified Kanhan classification, in which a diamond was added. This one is for nose and this is for nasal floor. But in classification, we'll be using nasal floor only. So 1, 2, 3, 4, and then for the left side, 5, 6, 7, 8. This will be the hard palate, posterior to incisive foramen, then 10 and 11 will be soft palate again. Now this is the views classification for cleft palate. For group 1, it was soft palate only. For group 2, hard palate and soft palate, but not till incisive foramen. Third one is unilateral cleft lip, and fourth is complete bilateral cleft. For the management protocol, it can be a preoperative, primary operative, and secondary management part. For the preoperative, feeding, since it was a major problem, and once the child is having feeding problem, it will lead to calorie deficit, and calorie deficit will be there, and then what will happen, the patient or the child will have growth problems. So feeding is a primary problem. Also, this patient is having aerophagia, that is he sucks in air along with the food. To prevent that, the patient should be fed in sitting up position. Haberman nipple should be used. Haberman nipples are basically what? The larger nipples. That should be used. Bowl and spool can be used. Feeding tubes or dropper can be used if nipples are not available. Next comes the nasoalveolar molding. We do this to decrease the size of cleft. Third is pre-surgical orthodontic treatment. It could be extraoral or intraoral. Intraoral can be passive like obturators and active like Latham appliances. Now coming to primary operative procedure, it includes lip closure and palatal closure. And for secondary management, it can be a rhinoplasty or scar revision. Also, there can be closure of palatal fistula, pharyngoplasty, alveolar bone grafting, orthodontic treatment, or orthognathic treatments. Coming, this slide signifies the importance of various authors. First one is Millard criteria. So basically, he gave rule of 10. For cleft lip, it is 10-pound weight, 10 week, 10 gram percent hemoglobin, and 10k cc glucoside count. While for cleft palate, the only change is 10 months. Second, Victor View was the one who was known as father of cleft surgery. And third is Newdorf principle. He stated that deficient vermilion on cleft side can be reconstructed with excess on non-cleft side. Next is Millard's philosophy. Millard stated that Millard's rule is also known as rotation advancement. So basically, he said two folds like rotation and advancement should be developed and reorient displaced muscle to give bulk and promote the growth. So goal for cleft lip regeneration or correction will be preservation of height and width, generation of natural cupid bow, symmetry of white roll maintenance, and nostril floor reconstruction at the time of cheloplasty. Coming to the surgical procedure for cleft lip repair, and we'll be discussing this in next video. Thank you for patient listening. Stay tuned for more.